Greetings. Welcome to session 1 of the Lurie Children's Pediatric Surgery Roundtable Series. In this session, we will introduce you to pediatric surgeon Dr. Mehul Raval, as he will be discussing what's new with acute appendicitis. My name is Chad Worley. I'm your moderator today, and I'm the Lurie Children's physician liaison for the North Suburbs. I'm joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. I'd like to introduce you to Dr. Mehul Raval. He practices general pediatric surgery and surgical oncology. He treats newborns, infants, and children with a range of conditions spanning from newborn through young adulthood. He has extensive experience in neonatology surgery and endocrine surgery. He is particularly interested in conditions related to the thyroid and using minimally invasive surgical techniques, including robotic-assisted surgery. He also has a particular interest in inflammatory bowel disease. For our community partners that have joined us, I just want to remind you that your referral guide and toolkit will be delivered to your offices by the end of May. If you have any questions regarding your toolkit, please reach out to your liaison. And community providers, I also like to remind you that not only is the toolkit on our website for you to access, but we have all the patient referral information, outpatient provider schedules, contact resources, pediatric specialties by location, and a library of all of our virtual programs right at a click of your finger. Just go to luriechildrens.org/physician services. All that information is right there. You can either access on your computer, download it, and print it, and it'll be there for you. But without further ado, I'd like to go ahead and turn it over to Dr. Raval for his presentation. And you should be able to share your screen now. And welcome to our session. And thank you for joining us this morning, Dr. Raval.
Thank you, Chad. Thanks for the invitation. And I'm looking forward to spending some time with you all this morning. So today's topic, as Chad mentioned, is to give you all an update on what is new with acute appendicitis, one of the most common things that we deal with as pediatric surgeons, and I'm sure all of you have had experience with in your careers. So here are a few of my disclosures, and some of the research and things I'll be talking about today received funding from the AHRQ, as well as the NIH, as well as generous support from Lurie and Northwestern. So let's start off by bridging the subject of why are we even talking about appendicitis? And as you all know, abdominal pain is one of the most common reasons why children visit the emergency department. Every year, there's almost 8 million of the 119 total ED visits are related to abdominal pain. This is, as I mentioned, one of the most common reasons why children even, need to have abdominal surgery. And it accounts for about 250,000 hospitalizations annually. And this is, roughly about 90 to 100,000 children undergoing an appendectomy each year. There's about 30 to 40% of these patients who present with perforated appendicitis. About 1 million of these, there's about 1 million hospital days associated with appendicitis as a disease. So this is really important for us in our hospitals. And if you were talking to a group of family or friends, we estimate that 1 in every 10 folks or so that you talk to probably has had their appendix removed. So let's start with some of the basics that we all learned in medical school or we believe is the normal pathophysiology of appendicitis. The appendix, as you know, is a small piece of intestine right at the junction of the small bowel and the large intestine in the cecum. The appendix is about the size of your pinky finger. It's known as the vermiform appendix. And so it's a blind ending pouch with a dead end on one side and an opening on the other that communicates with the rest of the intestine. What we theoretically believe is happening is that opening gets occluded. A little fecal ball known as a fecalith, or maybe some lymphoid tissue that's hypertrophied, occludes the mouth of the appendix, and that causes an obstruction and perhaps even some inflammation. Eventually, the pressure in that blind ending pouch, almost like a balloon that the clowns use to make a balloon animal, starts to get bigger and bigger. And we feel like the first thing that's compromised is venous congestion. You lose venous outflow, and so that starts to make the swelling worse. The pressure then builds, and maybe you get some arterial compromise at that point, which then leads to an area of gangrene. If left untreated, that area of gangrene then perforates and then causes an abscess. Now, this is what we've all learned is the normal pathophysiology of appendicitis. But there's actually increasing data that that dates back over 100 years that talks about how this was really thought about and whether or not this pathophysiology and this natural history is actually accurate. So in 1886, Reginald Fitz, he's a pathologist at Harvard, he studied autopsy specimens from people who died of pelvic infections. He did see some cases that had mucosal ulceration and inflammation, maybe transmural inflammation, which is what we think about in the classic presentation I described to you. Others had some gangrenous changes, and others had areas of perforation. So he concluded, this is back in 1886, that appendicitis was a progressive disease, as I've described. He advocated for early recognition, early appendectomy, and then maybe some subsequent studies demonstrated that with early intervention, there were lower abscess rates. And that's really the dawn of the surgical appendectomy. And we've not really looked back since that time. But if you look at the autopsies, all the autopsies that were done in that era, about a third of patients also had evidence of prior appendicitis, meaning that the pre-appendectomy era, there were some folks that had spontaneous resolution of their inflammation, and this was common. And most of the surgeries that were done around the turn of the 20th century were really done because of patients that had recurrent symptoms. So they had appendicitis and it kept recurring. And so a lot has changed since the 1800s, right? We have antibiotics, which can now treat polymicrobial infections. Ultimately, in the 1970s, CT scans were developed with rapid uptake in the 80s and 90s, and I'll show you some data about that. So negative appendectomy rates really plummeted from 20%, which is quite staggering. 1 in every 5 folks that were getting an appendectomy were getting them done for reasons that were not appendicitis, down to nowadays it's less than 3% is the industry standard. Here at Lurie Children's, we have about a 1 to 2% negative appendectomy rate. So we're pretty good at diagnosing appendicitis now. And I'll speak to you more about that in a few minutes. We actually know a lot more nowadays about the gut microbiome, about bacterial translocation, and there's evolving theories and practices surrounding how you handle even perforations in the GI tract. So we're talking about things that we're learning from the adult surgeons, such as how to manage diverticulitis non-operatively. So here's some data. This is from the mid-2000s, 2007 timeframe, where you see some trends. The top line shows overall trends in appendectomy. It goes from being an era of open appendectomy to an era with the black triangles at the bottom showing the rapid uptake of laparoscopy, so laparoscopic appendectomy. The black circles on the top right side of the graphic demonstrate a combination of open and laparoscopic. And as you can see, that trend is going up, meaning that we're doing more appendectomies than we ever have. And if Reginald Fitz was correct, what you would imagine, if that's true, then since we're doing so many more appendectomies nowadays, we would expect that we would see a decrease in the perforation rates. And instead, what you see is that the perforation rates have been rock solid stable. The blue line actually represents adults, and the red line represents children. And this is looking from 2000 to 2010. And so once again, here we are, we're doing more and more appendectomies, and yet the perforation rate is remaining relatively stable. And so what this tells us is that that old historic model of the natural history of appendicitis may be one that is a bit antiquated. There may be some folks that rapidly progress towards perforation. There may be some folks that have more of an indolent appendicitis. And it's hard to distinguish those things. And ultimately, maybe we should be thinking about new treatment paradigms. And so I'll be telling you a little bit about that with this talk today about what's new in appendicitis. Interestingly, this was one of the things that really we were curious about. And the AHRQ had endorsed a national quality metric known as NQF or PQI measure 2 for perforated appendicitis admission rates. And we were curious about this metric as a quality measure for communities and community access to healthcare. Because what we know is that once a patient reaches the doors of an emergency department or of a hospital, the delays that happen there are not necessarily that significant, and people are getting pretty timely care. What we worry about is whether or not patients are seeking care in a timely fashion to begin with. So are they making their way to their primary care physician or pediatrician? Are they making their way to the healthcare system? So this is Katie Baxter pictured on the screen. This is a paper that we published in JAMA Surgery a few years back. And as a research fellow, she was curious about this question about community access to care. So one of the things that we did was we actually looked back at the year prior to presentation with appendicitis and made sure that those patients had had a well child check, an annual physical with their pediatricians or primary care physicians in the year prior. And if they had, what we found is that they actually presented a little bit earlier and had a lower overall perforation rate, meaning that your relationship with your primary care physician, and therefore a proxy to your relationship with the healthcare system, is an indicator of whether or not you're going to seek urgent care in a prompt fashion. And this was the first time that we'd really made that correlation between that relationship with primary care and then an acute care intervention like surgery. So this was a nice contribution by Dr. Baxter. Let me go ahead and advance my slide here. So one of the first updates that I'll give you is related to imaging and how we diagnose appendicitis. And on the left, you see the traditional CT scan, and on the right, we see ultrasound. And so I'll talk to you a little bit about those modalities. What's important to understand is that for many years now, CT scans provide a lot of useful information. They give us a very clear picture of what's going on, but they also have a downside, and that's the ionizing radiation that they expose children to. And so this is a Choosing Wisely campaign that you may be familiar with. It's led by the American Board of Internal Medicine. This specific Choosing Wisely recommendation was actually endorsed by the American College of Surgeons, the American Academy of Pediatrics, and the American College of Radiology. And the basic premise, and I'll just read the blue part here, is don't do CT scans for the evaluation of suspected appendicitis in children until after you've at least tried an ultrasound or considered it as a serious option. And so this has been a recommendation for many years, and there's been quite a bit of work to try to decrease CTs, and even when using CTs, to image gently with decreased radiation doses. I don't have a lot of time to go into this, but there's a plethora of literature about the long-term risks of ionizing radiation and future malignancies in children specifically, and the utility of this type of recommendation. These are a couple papers, one of which is by some of my colleagues here at Lurie, Dr. Lautz in my division of pediatric surgery, as well as Cindy Rigsby, who's the head of our radiology department, looking at MRI and the use of MRI for diagnosing appendicitis. MRI provides us with a lot of really fantastic cross-sectional images, but also eliminates the use of any type of ionizing radiation. The other paper that's listed on this screen is out of the group out of Penn State, which had a large series using MRI, and they pretty much went to 100% of their patients get an MRI right off the bat. Here at Lurie, we do, this is our normal algorithm. We always try to start with ultrasound. If we can diagnose appendicitis with ultrasound, then we're done there. If not, if there's an equivocal finding or we can't visualize the appendix due to some limitations, then maybe we go to MRI next. We really rarely use a CT scan for the diagnosis of appendicitis. In fact, one of the most recent contributions we've made at Lurie Children's is that we're national leaders in the idea that postoperative abscesses, which happen anywhere from 10 to 20% of cases of perforated appendicitis. So this is after the patient's in the hospital, they're still having fevers, they're not progressing towards home. We're worried there's an abscess, so we want to image them. We're actually using MRI even for the postoperative imaging to identify the abscesses, and then maybe using interventional radiology to place a drain based on that MRI. And so this is kind of our algorithm here at Lurie Children's. Andrew Hu is one of my research fellows who's now applying to pediatric surgery. This is a paper we just published in the Journal of Pediatric Surgery last year, where we looked at barriers and facilitators to CT scan reduction at children's hospitals throughout the United States. This was a qualitative study, so we did a lot of interviews of pediatric surgeons, pediatric radiologists, emergency room physicians, et cetera. And we found that there were some key drivers that were important to changing local practice. One of them was just simply availability of resources, having an ultrasound tech available 24/7, having pediatric radiologists on your staff, et cetera, or even having MRI capabilities after hours. The second key driver was having an established protocol or care guideline for folks to follow, and having the buy-in of the frontline staff to follow that care guideline and algorithm. The third one was having a culture of intra-departmental collaboration. This involves stakeholders from surgery, emergency medicine, and radiology, as well as nursing. And so having that collaborative nature in your institution is important. And then the last thing was having a presence of a radiation reduction champion. This could be a surgeon who is very passionate about the topic, or a pediatric radiologist, or an emergency room physician, but ultimately having a champion who really owned and facilitated the entire process. So I thought this was a great contribution by one of our fellows. All right, the next controversial topic for which I'll give you an update is the timing of surgery. And this is the hypothetical of if the patient shows up at 9 p.m., 10 p.m., 1 a.m., do you do the surgery in the middle of the night, or do you wait till the next morning? And this is a debate that's gone back and forth in the literature. Perhaps the best paper that I saw in the literature about this was actually published by a colleague of mine, Dr. Boomer, who's down in Virginia. This was published in Annals of Surgery, a very highly respected journal in our field. They combined data from one of our big quality improvement collaboratives known as NSQIP with really granular clinical data from 6 institutions across the United States. They had over 1,400 patients or so. And what they found is that unless you're having exorbitant delays, 16-hour delays from the time they present till the time they get to the operating room, that waiting a few hours really does not make much of a difference. The way that I explain it to patients and families is that once we give the first dose of antibiotics, and we typically use Rocephin and Flagyl, or ceftriaxone and metronidazole as our first-line antibiotic treatment for folks that have no allergies. Once we give the first dose of that, it kind of halts the appendicitis in its tracks. And if you're thinking about that progressive natural history that I started the talk off with, it kind of keeps it right where it's at and allows us to have time to get to the operating room. What we did find here at Lurie, this is a paper just published in February, so just 2 months ago from our institution, is we looked at about 942, so nearly 1,000 patients. And what we found is that with an expedited care guideline, we were able to get patients to the operating room with shorter lengths of stay overall. We saved about 11 hours on their length of stay, less costly admissions, and readmission rates and other balancing measures were relatively the same. We at Lurie, we use a surgeon of the week model. So there's constantly a surgeon available for these types of acute care surgical interventions like for appendicitis. And in that way, we try to expedite care in the evening hours, as well as during daytime hours. We have a surgeon available pretty much 24/7, 365 days a year, available to take care of these patients and get them to the operating room in a timely fashion. So that kind of answers the question of does it need to be done in the middle of the night? The answer is it doesn't have to be done, but we do have the resources and capabilities to get it done in a timely fashion. Perforated appendicitis. Should you strike while the iron's hot, or should you cool it down? That's what the igloo is meant to represent. And so the idea here is that when a person already has perforated appendicitis, the imaging, the ultrasound, the MRI, the CT or whatnot, demonstrate that the appendix is already ruptured. What should you do? Should you go in while things are inflamed and irritated and try to do the appendectomy? Or should you cool them down with antibiotics, waiting anywhere from 3 to 4, maybe even up to 6 weeks, and bringing them back when things have calmed down? So once again, this has been heavily debated in the literature. There's actually 2 randomized controlled trials that were conducted. One out of the group out of Kansas City, Missouri, and one out of the group in Memphis, Tennessee. We don't have a lot of randomized controlled trials in pediatric surgery. It's hard to randomize. We have sample sizes that are small, things along those lines. But when we do have randomized trials, this kind of level 1A evidence, we should kind of pay attention. And so I'm going to just hit the highlights here very briefly. But both of these studies showed that with initial operation, Maybe the total number of healthcare visits were a little bit lower. Perhaps the number of CT scans or imaging studies that were needed were lower. And ultimately, what they concluded, at least out of the Kansas City one, was that clinically there wasn't much of a difference. Maybe it's surgeon preference. This is the Memphis group. They had fewer number days with central venous lines for IV antibiotic use. They had lower overall antibiotic use in the early appendectomy group, and a little bit lower length of stay overall when you combine the readmission for the subsequent appendectomy, the lower length of stay for the early appendectomy group. So this group actually concluded that early appendectomy was the way to go. And then ultimately they had some follow-up studies to each of these randomized trials, and they found that the kids were getting back to their baseline activities a few days earlier for early operation. There was a lot of cost savings related to the long-term antibiotic exposure. Quality of life metrics were actually better, especially for parents, about 12 weeks out. And that's probably the time that they're coming back to the hospital for the interval appendectomy. And so with all these data, the field has pretty much moved toward very sparingly trying to use a interventional radiology drain and delaying the appendectomy. We've pretty much uniformly adopted the policy that if we can, we will go in and get the appendix out, even in the setting of perforated appendicitis. All right, so when do we discharge patients that had early acute appendicitis? This is a paper published in JAMA Surgery that I was a part of a few years ago that looked at over 22,000 patients. And what we found is that same-day discharge, meaning you come in through the ER, we diagnose you with appendicitis, we get you to the operating room, we can send you home the same exact day with no untoward outcomes, no higher readmission rates, no higher abscess rates or anything of that sort. And so this kind of set the stage. And actually just this March, so last month, we published a follow-up to this paper. This is by Wynne Sullivan, another one of my research fellows, who published a study looking at, since the time that original study was published, now 5+ years ago, what have the trends been in terms of same-day discharge? And same-day discharge is becoming more and more common at many children's hospitals across the United States. But what you find is perhaps that there are some populations for specific racial and ethnic groups, minority groups that perhaps are not receiving the same level of care, meaning not having same-day discharge as much. And so to deliver really equitable health care, we suggest folks come up with an algorithm, an objective measure for being able to identify who's a great candidate for same-day discharge after appendectomy. And so these are now, if you think about them as more modern day quality metrics or ways to kind of get even better, these are some things that we can start to do. The last big topic I'll talk about is the role of antibiotics in managing acute appendicitis. And actually the duration of antibiotics for managing appendicitis versus surgery. So this is a multi-institutional collaborative study looking at the association of non-operative management of appendicitis using antibiotic treatment versus laparoscopic appendectomy. And this was led by Pete Minechi out of Nationwide Children's in Columbus, Ohio, who's been a longtime friend and colleague. Dr. Cabre, one of my partners, was one of the co-authors and contributors on this manuscript. So here at Lurie, we participated in this multi-institutional effort. And it was a really powerful study in the sense that it showed that using antibiotics alone can treat early acute appendicitis. And there's some caveats and some nuances that I'll briefly mention. But what we have to counsel patients and families about is that it has a success rate of about 60 to 70%, meaning a 30 to 40% of patients that you offer antibiotics to are not going to have resolution of their right lower quadrant pain and ultimately are going to need to have a laparoscopic appendectomy. The keys here are understanding that patients that have a fecalith or perhaps look like they are concerning for perforation based on their imaging, they are not candidates for this type of intervention. For those patients, we need to do the laparoscopic appendectomy for sure. But if it's early acute appendicitis and it's just inflammation, then yes, 60 to 70% of the time, we could treat it with antibiotics and expect success. And so that's I think, a patient and family-driven decision that talks a lot about making sure that they have all the information they need to make the most informed decision for themselves, have the autonomy, but have the data. And so this is something that we do offer occasionally here at Lurie. There are some families that are very averse to surgery and are interested in this. We don't ubiquitously offer this to patients. It's really those patients that we've selected, those that are not having a fecalith, not having a perforation, and have a strong preference towards this treatment modality. And we make sure we educate them about the chances of success. The good thing to know, though, is that even if you try antibiotics and they fail, patients usually do not present with perforation. They present still with early acute appendicitis and can get back into that rapid recovery, maybe even same-day discharge pathway. This is a great paper out of the New England Journal that talks about duration of antibiotics. This was a mixed study of adults and pediatric populations looking at a lot of abdominal sepsis types of procedures. Appendectomy was one of the procedures they looked at. And what they found is that shorter courses of antibiotics, 3 to 4 days, for example, do just as well as longer courses of antibiotics, 5+ days. So even when patients have perforated appendicitis, in the old days, we might have treated them for 10 to 14+ days of antibiotics. Now we are looking at this type of literature and reducing our antibiotic durations quite significantly. If patients are now afebrile, tolerating a diet, and ready for discharge, we're limiting their course of antibiotics to as short as 5 days. For perforated appendicitis, on average, it's been about 7 days of antibiotics is what we're using. The key is to have a clinical practice guideline. Dr. Ingram, one of our research residents, prepared this manuscript back in 2021, which took a bunch of algorithms from a bunch of hospitals and really tore them apart and put them back together again, really looking for the essential elements that you need to have in your clinical practice guideline. This is just a screenshot. I don't expect that you're able to read it, but just to know that we here at Lurie, we do have a clinical practice guideline. We categorize the appendicitis to see whether it's early acute appendicitis, all the way through the spectrum of disease that we see to florid perforation and contamination with peritonitis. And so we have different treatment algorithms in place to manage all of those different types of appendicitis, so to say. And we have a really keen eye towards antibiotic stewardship with limiting our antibiotic durations. Our early acute appendicitis patients only get a single dose of antibiotics prior to surgery, and that's it, all the way through, as I mentioned, 5 to 7 days for our perforations or as needed. This type of algorithm works. This is a study done once again here at Lurie where we looked at our length of stay. This is in hours for early acute appendicitis. We were already doing pretty well. What we see, this is length of stay in day. What you see is that we were averaging about a 1.4 day length of stay back in 2016. And then as of the data that I had pulled more recently in 2020, Q2, we had gotten down to most of these patients going home in about 0.9 days or less than 24 hours. And so this is pretty impressive trajectory where we are taking good and making it even better. I'm really proud of the work that we're doing and continuing to do to advance the care for appendicitis at Lurie. And that's really about all I have. We obviously have our main hospital address here, and then you all know how to reach out to us and refer patients to us. I'm happy to take any questions at this time. This is a pre-COVID picture of our group. It's evolved a little bit. There's a few folks that have come and gone and that are not quite in this picture, but we'll update it soon. But nonetheless, really looking forward to answering any questions you all have.
Thank you, Dr. Raval. That was great. I think I could sit here and listen to you present on acute appendicitis all day. You're wonderful today. That was really great. You know, in my excitement of turning the video over to you, I failed to mention to the audience that we really encourage engagement here. And if anybody has questions, please type them in. We do have a larger audience, so I don't think we're going to be able to take anybody's live question, but if you please type them in, I'll go ahead and read them out for you. But real quick, before I read the question, Dr. Raval, on that appendicitis algorithm that you showed, it seems like somebody would be interested in that. If one of our partners reach out to Julie, Paula, or myself and ask to see that, would you be able to share that with one of us so that we can share that with them?
100%. Yeah, absolutely. For those of you that are on There's two ways to get it. Obviously, you can email it to you or electronically get you a PDF version of that. It's pretty evidence-based. Some of the literature that we use to inform that clinical practice guideline is referenced. And so if anybody's interested in learning more, there's always opportunities there. It's evolutionary, right? It's just like any other quality improvement project in the sense that it's PDSA cycles. And as we get data, we tweak it. And so we'll get you the most up-to-date version for sure. And then for any folks that are a part of our network that have access to Epic under our clinical practice guidelines that are available through the Epic drop-down menus, they're there for a public consumption. We want all of our emergency medicine colleagues using it, our radiology colleagues, our pediatric colleagues throughout the system should have access to it.
Wonderful. Thank you for that detailed answer. That's great. So Michael Peters writes, how often do your patients receiving MRI require sedation? And thank you for your excellent presentation.
Yeah, of course. So I wasn't able to get into a lot of the details related to the MRI protocols, but they're a rapid MRI. They're really fast. And so they're not the typical MRI where the kids are stuck in the MRI tunnel for like an hour with different sequences. It's really like essentially my limited knowledge of radiology. It's like a T2 weighted imaging modality, really looking for inflammation and fluid collections. It's really fast, on the order of like, I think 7 to 12 minutes is what it takes. Most kids tolerate it. We do not provide sedation for that. Most kids tolerate it really well. And for some of the youngest kids, believe it or not, what we've done is in a kind of innovative, creative way, we've actually had a parent, a mother or father, lay down on the MRI scanner and just kind of gently hold their child, and we scan both, and then we're able to do it. I think it happens exceedingly rarely that we can't get the MRI. And once again, we've already tried screening with ultrasound first. And so, it's kind of a series of filters, so to say, before someone would get to the point where we have to do a CT. And as I mentioned in the talk, I think it's been over a year, maybe 2, since we've had to do a CT scan because of some of these types of, challenges.
Okay. So how long do you usually recommend kids wait to return to school and to return to gym class or sports for routine API with no complications? This was from Dr. Mark Miner.
Yeah, so there's going to be some recovery and debilitation. I think it usually has to do with how sick they were coming into the surgery and then kind of mirroring that on the tail end. So if they've only had symptoms for a day or 2 and we do a laparoscopic appendectomy for early acute appendicitis and get them home the same day, I'd say only another day or 2 at home before they can go back. And so they're not missing a lot of school. We do have some restrictions in terms of returning to sports, heavy lifting or contact sports specifically. We have some recommendations related to wound care. We provide our patients with those, and we actually try to keep those as up to date as possible. I believe the rule of thumb right now is that most folks are going to say avoid swimming or submerging the wounds for 1 week. And then typically, at least for folks that are swinging tennis rackets, baseball bats, or doing any kind of core exercises, we worry about, incisional hernias, especially at the belly button incision in a laparoscopic appendectomy. And so we usually say about 2 weeks of taking it easy before getting back, slowly, gradually getting back into the full swing of things. By about a month out, kids are at 100%. They're back on their ball teams and playing their organized sports, and it's great. So the recovery is actually quite prompt. And I think that the 2-week recommendation is a loose one, meaning that there are some folks who can get back a little bit sooner, and there's some folks who are going to take a little bit longer.
Sure. Okay. Thank you. So Chris Speaker writes, and this will be the last question. You have mentioned the ability to treat uncomplicated early appendicitis with antibiotics in the absence of fecal. How sensitive is ultrasound at detecting them?
Pretty good. It's pretty good. Yeah. So in the study that Dr. Minechi did, which once again, Lurie did participate in, fecalists were identified accurately, I would say 95% of the time. And then the reality is that the failure rate of managing with antibiotics alone for patients with fecalith was much higher. It was on the order of like 70% failure, I believe. I have to look back at the data for the exact number, but I think it was the majority of patients that had a fecalith were not successfully managed with antibiotics alone. So ultrasound is pretty good at looking at identifying the fecalith. There's other features that we call secondary signs in ultrasounds. These are things like how dilated or compressible the appendix is, whether there's any surrounding inflammation and lymphadenopathy, how the bowel is peristalsing nearby the inflamed appendix. All these secondary signs are can really help improve the sensitivity and specificity of ultrasound in the diagnosis of appendicitis, even when on occasion you can't necessarily visualize the appendix. So we do rely on labs, we rely on the secondary signs on the ultrasound. We really try to avoid additional imaging if needed. Keep in mind, 20, 30 years ago, appendicitis was a diagnosis that was made with a good history and exam. And so, it always starts with that. And so for that, I encourage everyone to keep your clinical acumen and your antennas up. We trust your judgment. Absolutely. We verify with some of these additional tests, but our pretest probability is really what's driving our decision to go to the operating room. So yeah, hopefully that answers that.
Okay. There's one more question that came in. I'd like to get that real quick, squeeze it in if you have another minute.
Sure.
And, Mark Freed writes, do you have an opinion for management for smoldering, prolonged RLQ pain when the imaging is negative or equivocal?
Yeah, I'd say every year there's a patient or two that comes to my clinic that has had this chronic right lower quadrant pain. We can't quite figure it out. And there's a couple common things that we want to make sure that we've ruled out, making sure we're not missing things like inflammatory bowel disease or any other type of underlying issue. But then many times, as described, these things are just ruled out, they're negative, and this right lower quadrant pain persists. And so I think that having a real candid discussion with the family about the merits of an elective appendectomy is worthwhile. Some folks have heard the discussion, heard the risks and benefits, and decided not to pursue that. Others have said, yeah, you know what, we keep presenting to the emergency department and to our doctor's office with this pain. Appendicitis keeps coming to the top of the differential. People aren't willing to dig further into it unless we've ruled that out over and over and over again. Mm-hmm. And I think that, there is a benefit to considering surgical intervention at that time. Once again, we do have our risks and benefits that need to be candidly discussed, though.
Thank you. Like I said, this was great. For everyone who's still on the line and who will be watching the recording, if you're interested in meeting with Dr. Raval in person or with a live video chat and want to discuss some of his interests, such as thyroid or inflammatory bowel disease, I know he would like to do that. So please contact your liaison. So that'd be myself, Paula, or Julie. And we would love to set up a meeting with you, Dr. Raval, to meet some of our community providers in person.
Absolutely. Anytime.
Thank you. And thank you all for joining us today. This is recorded and we'll be sending the link out to you and all your colleagues by Thursday or Friday or in a couple of days, and we'll get that out to you. But I'd like to remind you to please join us later today at 12:30 as we will introduce you to Dr. Guillermo Aries and APRN Alyssa Williams, as they will be presenting adolescent bariatric surgery, who benefits. So until then, thank you for joining us and have a great day.